The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. Thank you so much for joining us for this webinar. We're going to get started in about 2 minutes. I'm going to give a little time for latecomers to trickle in. So we'll get started in about 2 minutes. Thanks so much. Okay, so we're going to get started. Thank you so much for joining us here today. My name's Tanya Landhecht, and I work with Cure Search for Children's Cancer. I run our research and educational programs. This is the first in a series of 2 webinars that will provide guidance to school personnel and to families who are seeking advice for their schools about what to do when a student is diagnosed with cancer. Today's webinar is about what school personnel, school nurses, school social workers, anyone who's engaged with a classroom can do when a child has just been diagnosed with cancer. The webinar is going to start with a general discussion of childhood cancer. For those of you who might not be familiar, it will go through its incidence and some of the short and long-term effects of cancer treatment. This background is going to set the stage for some practical guidance about how to support a student in school with cancer. The presenters are going to share advice about how to provide home hospital instructions, what to tell classmates and faculty, and how to prepare for the child's eventual reentry into school. I also want to encourage you to register for the next webinar that will be on reintegration into the school environment. This webinar is going to take place on Monday, November 3rd from 3 to 4:30 Eastern Time, and I will also send that out in an email to all the registrants of this webinar after it's over. I also wanted to let people know if they want to share these webinars, we are going to record them and I will email them out to everyone. Before I introduce the speakers, I also wanted to say that both of these webinars are supported by a really generous grant from Ronald McDonald House Charities, so we're very grateful to them for their support. So I want to introduce today's speakers before they begin. Dr. Michael Amylon was born and raised in New England. He received his undergraduate degree from Brown University and moved to California as a medical student at Stanford, where he earned his M.D. After continuing at Stanford in a pediatric residency and then a postdoc fellowship in hematology oncology, Dr. Amylon joined the faculty of the Stanford University School of Medicine. His early research interests included clinical trials in the treatment of pediatric leukemia and lymphoma. He has a long-standing interest in the psychosocial impact of pediatric cancer and its treatment on patients and families. He has been extensively involved with Campo Kaiser in California, a program of peer support, respite, monitoring, mentoring, and recreation for children with cancer and their families. He serves as the medical director and vice chair of the board for the Oncology Foundation. He previously served as a member of the American Cancer Society's peer review committee on psychosocial and behavioral research, and currently is a member of the board of directors of COC1 and chairs the research and education committee. And our other terrific panelist is Kathryn Wissler. She started her career as a special education teacher and administrator and later served for 18 years on the faculty of the University of Rochester Medical Center as the Educational Liaison for Pediatric Hematology Oncology Division. In that capacity, she provided guidance and advocacy to school districts and parents of children who had educational issues arising from the diagnosis and treatment of cancer, including the late effects of treatment. She's currently an educational consultant to families with children who have cancer and other serious illnesses. So thanks again to Ronald McDonald House Charities for their support. And I'm going to switch the presentation controls to Mike.
All right. Thank you very much, Tanya. And good afternoon, everybody. It's wonderful to see so many people here with an interest in this topic. I've been taking care of children with cancer and their families for many, many years. And since school is one of the primary jobs that children have, and since our goal in treating a child is to get them back into sort of a normal developmental progression on the path to being a productive adult, it's really important that we help them to be successful in the school setting. And what we do to them at the hospital makes that sometimes very challenging. And so it really requires teamwork among the hospital personnel, among the school professionals, the parents, and the kids to make that happen. And it's great that all of you are here so that we can have this discussion about how that can work best. What I'm going to try to do is set the stage by giving an overview of what really having cancer is all about for a child and their family. I'm going to try to sort of give the context, and then later on in the presentation, Kathy will give some more specific examples of how to talk to the school personnel or the students or other people about the specifics. So my goal is really to educate you, and then she will help you with how to educate the other people that you need to interact with. So the slide doesn't appear to be advancing.
Let me just see. Okay, try it now.
All right, there we go. So what I'm going to do is talk a little bit about what cancer is. We hear a lot about it in the media these days, and there are a lot of medical shows on TV where they anxiously wait for that biopsy to come back as benign or malignant, but a lot of people don't really have a very good idea of what that actually means. Talk about the causes of cancer, the fact that there are lots of differences between the kinds of cancer that children get as compared to what we hear about in adults, and a little bit about what those kinds are, and then talk about the incidence and survival statistics in children. So let's start with the concept of what cancer is, and again, I'm having trouble advancing the slide. There it goes. So everybody has heard the word cancer, and most people have had some personal experience either with a family member or a close friend who's been impacted by cancer, but a lot of us don't really understand biologically exactly what that means. And I think probably the first important message is that it's not one disease, it's many different diseases. And so when we talk about the cure or finding the cure for cancer, that's a little bit simplistic and unrealistic. But there are two important conditions biologically for a disease process to be called cancerous. The first one, and the one that is probably most obvious, is that some type of cell in the body escapes from the normal controls on growth and proliferation. In the usual context, all of our different tissues are very carefully balanced so that everything is present in the right amounts for the optimal functioning of our body as an organism. And so if one type of cell is growing, when it reaches the point where there are enough of whatever that is, then there are signals that tell it to slow down or stop. When something gets a little bit low, then there are other biological signals that tell it to start growing again. And if either a cell doesn't respond to the stop signal, or if it somehow gets its grow signal stuck in the on position, then those cells will just continue to increase in number even when there are more of them than there ought to be. And depending upon what kind of cell that is and where it's located, that can start to interfere with the function of normal tissues around it. And that's the first condition. And if that was happening in a localized location, there would be a lump somewhere on the body that we would call a tumor. And then that comes to that point in the medical TV shows where they get a biopsy and send it off to the pathologists, and you anxiously await the diagnosis of whether it's benign or malignant. And that relates to the second characteristic that I have listed here, is that those cells need to have the ability to break away from wherever that spot is that they originally made the mistake in their growth controls, and be able to take up residence in remote locations in the body. We call that process metastasis. Tanya, I think I'm going to have to ask you to advance the slides. It doesn't seem to be working. So what causes cancer? That's obviously something that we all would be very interested in finding out. And in the adult context, there's a lot that we do know. Everybody is familiar with the fact that if you have a 40-pack-year history of smoking cigarettes, then your likelihood of developing lung cancer is much higher than it otherwise would be, and a very large proportion of the lung cancer cases that we see are related to smoking in adult patients. If you spend too much time in the sun, then your risk of skin cancer is going to be increased. There are some dietary habits that relate to the incidence of colon cancer and breast cancer. So we have at least some knowledge and context about the causation of cancer in many situations in adults. In children, though, the causes of cancer are generally unknown. And it sort of makes sense that the kinds of environmental influences that we relate to adult cancers are not going to be operative in children, because if it takes 40 years of smoking cigarettes to get that lung cancer, then if you're 2 years old, obviously that kind of a situation is not going to be relevant to how you got cancer. There are a few rare types of childhood cancer where there is a strong genetic component. There are some that actually are directly inherited from parent to child, in particular retinoblastoma, which is a cancer of the eye, the retina tissue in the back of the eye. But in most cases, we have no idea where it comes from. And children, as a consequence, there are really innocent of whatever has caused the development of their cancer, whereas as adults sometimes we are complicit to some degree in why we have that cancer. Kids are innocent in many things, and so obviously that makes it even more important that we do everything that we can to help them out and help them to deal with that. If I can have the next slide.
Mike, why don't you try advancing now? I think I've successfully moved it to you. No?
No, it's still not working. So I mentioned the fact that what kids get that we call cancer is very different from cancer in adults. Kids do not get lung cancer, they do not get colon cancer, they do not get breast cancer, they do not get prostate cancer, all of those things that are so common that we see in the public service announcements on TV. What they do get are cancers that arise from cell types that are very primitive in their development and that tend to grow very rapidly and move around a lot. And if you think about the fact that in what creates a child, you have a fertilized egg that over a period of 9 months has to go from one cell to a very complex organism with many different types of tissues that relate to each other in different ways. Those cells are growing very rapidly, they're moving around, they're adapting and developing rapidly. And so that type of cell that kind of gets stuck in a phase where it's supposed to be growing rapidly and doesn't move past it, perhaps, is the reason why cancers arise in children. But biologically, we notice that they are much more aggressive than the tumors in adults. Historically, that led to a very poor prognosis. When I was a medical student, we were taught that essentially pediatric cancer was incurable, and your life expectancy, if you were a child diagnosed with leukemia, was measured in weeks, perhaps 6 to 8 or 10 weeks, because these cells are so aggressive. But these same biological properties make them more responsive to the types of treatment that we have developed, And so as a consequence, our success rate in treating children with cancer has improved remarkably in recent years. So I can have the next slide. In kids, leukemias and lymphomas are by far the most common cancers. Altogether make up about 1/3 of all cancer diagnosis in kids. Brain and central nervous system tumors are second in line, and then there's a whole variety of different types of solid tumors that arise in different kinds of tissues. So osteogenic sarcoma and Ewing sarcoma in bones, neuroblastoma in nervous tissue, Wilms tumor in kidneys. There's a type of cancer for every type of organ or tissue cell that we have, but most of those, when you look at them as a group, make up a very small number. Cancer in children in general is relatively rare, and that's a good thing, but as a consequence of that, sometimes it's a little harder for us to find out how the different cancers work and how they respond. It's one of the things that has forced pediatric cancer treaters to combine their efforts into multi-hospital clinical trials groups, and that really has been one of the things that has contributed most to our success. The successful treatment of children with cancer is now much more, much higher than it used to be. If I can have the next slide. The incidence of pediatric cancer is increasing in this country for reasons that we don't understand, and that relates to our lack of understanding about what causes cancer in general. That has something to do with our lifestyle and environment. We know that the incidence of cancers in undeveloped countries, pediatric cancers, is significantly lower than it is in developed countries, and we've been able to watch as the incidence of some cancers, particularly leukemias and lymphomas, increases in successive waves of countries as they undergo industrialization. But we're still trying to figure out what all those influences are so that we can get that incidence number going back down instead of continuing to rise. There are about 17,500 new cases of cancer in children 19 years of age or less in this country yearly. The survival rates, which used to be close to 0, are now approaching 80% for all comers. If you look at the outcomes for kids with any type of cancer, about 80% of them are going to survive at least 5 years, and the large majority of those are going to be cured of their cancer. But the cost that those children pay in terms of toxicity of the treatment and the impact of the disease is very high, and that's why they have so much trouble sometimes with school attendance and school performance. The survivors of pediatric cancer have a whole lifetime ahead of them, so that even though the actual incidence of pediatric cancers is lower than the incidence of cancer in adults, the number of years of life saved if you have a 2-year-old with neuroblastoma who's cured of their disease as compared to an older adult with prostate cancer, for example, the impact on society of saving that child is much higher. So when you look at the number of pediatric cancer survivors who are contributing in our society, right now there are over 385,000 pediatric cancer survivors living in the United States, and that number continues to go up every year as our success rate in treating these kids goes up. So it is a problem that has a big impact on our society and culture. The other thing that I really want to emphasize is that the diagnosis of cancer in a child impacts the entire family in a major way. Obviously, a child who's sick and needs to be in the hospital and needs to have surgical procedures or other kinds of painful medical interventions, needs to be getting medicines that are going to make them throw up or make their hair fall out. All of those things are easy to understand as difficult circumstances that require support, and we all would want to try to do whatever we could to help those kids out. It's also easy to understand how for a parent who's being threatened with losing a child, that is an extraordinarily difficult circumstance. I think that most parents couldn't imagine anything worse than having their child diagnosed with an illness that might be fatal. And so certainly the emotional, psychological impact is huge on the parents, but it also has a an enormous impact on the structure of their lives. Since pediatric cancer is relatively rare, there are not that many hospitals in the country that are equipped to care for kids with cancer, and so often families need to travel long distances to get to a treatment center that can appropriately care for their child. The kids are in the hospital sometimes for weeks or months at a time. If both parents are working, one of the parents almost certainly is going to need to take time off from work, maybe even quit their job altogether. Any kind of schedule that the family had will be completely thrown out the window. Planned vacations will have to be canceled. You know, just about every aspect of life is turned upside down for those families, and it's extraordinarily difficult often for the parents to muster the resources that they need just to get from one day to the next during the intensive part of the treatment. I also want to really emphasize the fact that the well siblings in the family constellation have a lot of needs, and they are often going to also be in your school systems when you have a student diagnosed with cancer, and so you shouldn't forget about them, because the world often does sort of forget about them. Siblings tell me all the time that they feel like they suddenly became invisible, that no one knew who they were, no one cared that they were there. If they meet someone walking down the street in their hometown, the question that they're going to be asked is not, hey, how are you doing? It's good to see you. It's going to be, hey, how's your brother? How's your sister? All of the energy and resources of the family and the community that supports the family is going to be focused on the illness, and that's natural and it's necessary for the parents to put that emphasis on curing the disease, but sometimes the kids kind of get lost in the cracks who are SIBs in that context, and so it's important to remember that they're there too, and to pay attention to them in the school context also. They're going to have some issues to deal with. So how do we treat cancer in kids? The first thing that became available to us was the surgeon's knife. And if you have some cells that are growing rapidly that stay in the place where they originally made that error, and you find a little lump and the surgeon takes it out and they get all of the cells that are abnormal and it has not yet spread anywhere else, then that can be a curative intervention. That's very rare in kids because of all those biological characteristics that I mentioned. The cells grow rapidly, they spread rapidly, so it's almost never the case that a surgeon by himself is going to be able to cure a child with cancer, but they can take out a big chunk of the cells, and in very rare instances that might be all that would be necessary. The second thing that became available to us was radiation therapy, where we focus a beam of radiation in the area where the primary tumor is. Radiation shares the characteristic with surgery that it is a localized modality. You are only treating the area where you aim that beam, so any cells that have already spread to more remote locations will not be treated. But the advantage that radiation has over surgery is that if, for example, a tumor is right in the base of the liver where all of the blood vessels that supply the liver originate, then if the surgeon goes in, they're not going to be able to take all of that cancer out without also damaging those blood vessels to the point that probably the liver won't survive, and without the liver the patient won't survive. So the surgeon is always limited by whatever normal structures are close to that tumor. They need to be really careful not to do unacceptable or life-threatening damage when they're in there trying to remove the cancer. The radiation therapist can aim their beam at the tumor, and generally, as I mentioned before, because of those biological characteristics of rapid growth, the radiation is more damaging to the cancer cells than to the normal cells, so that you can kill all the cancer, and probably you'll cause some damage to the normal tissue, but generally it can survive and recover. So some tumors that were not amenable to surgical treatment were successfully treated with radiation. But the thing that really made the big difference in moving our treatment goals in kids with cancer from sort of trying to prolong their lives and ease their discomfort for a period of time to aiming to cure them was the use of chemotherapy. And chemotherapy just means using drugs or medicines to treat a disease. The kinds of medicines that we use to treat cancer are very damaging. They're actually things that would be considered to be poisons if you encountered them in a different context. They kill cells that are growing, and so they kill cancer cells particularly effectively, but they also damage any other tissue in the body that is growing, and children are still growing in many ways. All of us have tissues that are growing and renewing themselves continuously, but in kids that impact is even higher, and that's one of the major reasons for some of the toxic side effects and the long hospitalizations that are necessary for children with cancer. A newer modality which is less toxic is trying to use our body's own immune system, our defense system against infection. If we could teach the immune cells how to recognize and attack the cancer cells the way they recognize and attack a bacteria or a virus or a fungus or some other infectious agent, then that would be a way that we could damage the cancer cells as part of the normal defense mechanism of the body and not do harm to normal tissues. And there are some ways that that can be done. There are some pretty effective forms of immunotherapy that are just now beginning to be more commonly used, and that will be something that hopefully will be increasingly common into the future. Hematopoietic stem cell transplant, you've probably heard of it as bone marrow transplant. You can also use umbilical cord blood as a source of those cells. That's a very highly toxic intervention where we give extraordinarily high doses of both radiation and chemotherapy that would be fatal to the patient because it would kill the bone marrow and wipe out all of their blood cells. And so by giving them someone else's bone marrow back to rescue them from that procedure, it allows us to give a high enough dose of treatment that we can kill all the cancer, and then the patient will still survive. But that's really a sort of a last-ditch effort if you don't have any other effective therapy available. It requires very long period of time in the hospital and then a long period of isolation during which time the body's immune defense systems recover. Those kids miss up to a year or sometimes even more of their school attendance and really need more intensive interventions. What I hope will be the wave of the future that will make cancer a little bit more easily treatable in kids and hopefully lessen the impact on their school attendance and school performance are some of the new biological agents that are just now being developed that focus on the specific things that make a cancer cell different from a normal cell. So we know that they grow really fast, we know they move around a lot, but we're just starting to figure out why that is happening. And looking at, it's now very easy to sequence the entire genome of a cancer cell and look at all of the genes, see which ones are acting differently than they normally should be, what's turned on when it should be off or turned off when it should be on, or is making a protein that's abnormal. As we learn more about that, hopefully we'll be able to manipulate those specific switches just in the cancer cells, the things that make them act differently than they're supposed to, and that kind of treatment will hopefully be both more effective and less toxic over the long haul. In the meantime, though, we're stuck with our surgery, radiation, and chemo for the most part, and there are a lot of both short-term and long-term side effects. In the short term, there are a lot of changes in appearance that make kids really anxious and nervous about going back to school. They often will lose their hair as a consequence of the drugs that kill growing cells. The hair is growing all the time, and so that's why cancer patients become bald. They often will have a change in their weight. They may not be able to eat very well because of all the nausea and vomiting associated with the chemotherapy, and they may lose a lot of weight and come back looking very thin. On the other hand, there are some diseases that we use glucocorticoid steroid hormones as part of the treatment, and they cause the kids to eat a lot and gain a lot of weight, so they might come back with a very round face and a very round belly. In either case, those changes in their appearance are going to make them nervous and awkward and worried about whether people are going to make fun of them or whether they're going to recognize them, how they're going to react to them. There may be various devices that the kids need to bring with them when they go back to school. This child has what we call a nasogastric tube that's inserted in his nose and goes down into his stomach that we can use to feed him because he's not able to eat very well by himself. There are some kids who have devices which allow us to access their blood system, large veins, and they may have a plastic tube that comes out of the skin on their chest that we call a Broviac or a Hickman catheter. They may have devices that are inserted under the skin to allow us to access the fluid in around their brain that we call an Ommaya reservoir. They may have a shunt if they have a brain tumor that's also inserted under the skin on the skull to help drain fluid from the brain. So there are a lot of things that they may have that will make them nervous, that other kids might notice, that they'll be anxious about getting asked questions, and that they'll need to be careful to make sure that they don't get broken or injured or in any other way interfered with while they're in the school environment. The treatment is very tiring. The kids will be very fatigued. They'll be lacking in energy. Nausea and vomiting are a common side effect of the chemotherapy. Suppression of the immune system so that they'll be more susceptible to whatever is going around in the classroom, whatever flu bug or cold or other kind of infection is there. They'll be more likely to get it, and they will have a more difficult time dealing with it. They will have a certain schedule for when we expect them to be in the hospital to get their treatment, but in between there are a lot of unexpected hospitalizations when side effects come up. There can be changes as a consequence of the radiation or the chemotherapy drugs in their hearing or vision that will make it more difficult for them to be successful in the school setting. And obviously the kids who have a brain tumor will have the potential of having much greater both physical and cognitive effects from the tumor or its treatment on their brain. Many of the medicines also impact peripheral nerves. They may have pain, or they may have difficulty with muscle function or balance. They may have trouble walking because of those things. So there are an awful lot of things that those kids need to cope with in the immediate period when they're undergoing their treatment. There also are a variety of later effects that can occur both from the cancer and from the treatment. They need to be taken account when you're planning the overall program of support, but they're not what we're going to be focusing on in this webinar. But even kids, when they're finished their treatment and are back at school full-time, may still have some learning disabilities or other things that need accommodations that you should be thinking about when you're planning their trajectory of school support. And those can include social issues, emotional issues, and physical issues, as well as things that are related to their cognitive abilities. So I'm now going to turn the control over to Kathy, who's going to talk to you more specifically about what things you're going to be facing and how you can deal with families and school professionals.
Okay, thanks, Mike. This is Kathy Wissler, and now that you've had an overview of childhood cancer and its treatment, I'm going to talk about how your school can support the family and student who has been diagnosed with cancer after the diagnosis, but before they re-enter school. So we're going to discuss the topics you see on the slide. We'll talk about establishing communication, home hospital instruction, what to tell the classmates, what to tell school personnel. We'll go into some more of the family stressors and how to support the family, talk about preparation for return, and mention standardized tests and homeschooling. There really needs to be a close collaboration between the medical and educational systems and family in order to support the school-aged patient diagnosed with cancer or brain tumor. This information is designed to walk schools through the different steps that will help the child be successful in school despite their diagnosis and treatment. Next slide. Okay. So usually the parent will contact the principal, classroom teacher, guidance counselor, or school nurse to tell them of their child's diagnosis. It's important for the school to first get a release of information from the parent and the child's medical provider to share information with the school. The parent should be told that any services that the school may need to put in place for the child during their illness, especially home hospital tutoring, will require documentation of the diagnosis, treatment, and projected length of absence from the physician. The school should then determine who is to be the case manager at school. The case manager will be the contact for both the medical personnel and the family, and will share appropriate information with each other staff as needed. We recommend the classroom teacher or nurse in the elementary schools and the guidance counselor or nurse in the middle school or high school be the case manager. Information shared should be based on what the school needs to know and who needs to know it. Think in terms of what the school needs to know in order to provide appropriate support for the student at home or in school when they return. Slide. Okay.
Kathy, you should be able to move them forward if you just click with your arrow.
Okay, I got it. All right. Home hospital tutoring. This may be one of the most important services a school can provide for the student with cancer. Tutoring can be a time when children can feel good about themselves, keep their mind off their illness and difficult procedures, and it serves to inject some normalcy into their lives. The main goal of tutoring is to keep children from falling behind their classmates during their illness. This will ensure a smooth re-entry to school when the child is well enough to return to school on a regular basis. Remember, the vast majority of childhood cancer patients will return to school within a year of their diagnosis and need to be prepared to move on with their class. Public school districts are required to provide home hospital instruction for children who are unable to attend school due to a medical condition at no cost to the family. A childhood cancer diagnosis may mean absenteeism from 3 months to a year or more. The number of hours provided for tutoring differs between states, but typically it is 5 hours a week for elementary school students and 5 to 10 hours a week for middle school or high school students. That may mean 1 to 2 hours per day or 2 to 3 hours 3 days a week, whatever the parent and the providers feels works the best. Tutoring runs during the regular school calendar, but it can also be arranged in the summer if the child is behind. It is preferred that if a child is well enough, they should attend school, but a cancer diagnosis means numerous doctor appointments, side effects from treatment, periodic hospitalizations when they will miss school, and it will be difficult to keep continuity of instruction if they miss sporadically over a long period of time. So more than likely, every child with a cancer diagnosis will need some level of tutoring during their treatment. Some children will not be medically able to benefit from instruction at diagnosis, but the hospital personnel should provide the school with written documentation of the need for tutoring and when it can begin. Sometimes the hospital has its own tutoring program at the hospital if the child will be hospitalized over a long period of time. They will request that the homeschool district contracts with them to provide the service. Otherwise, individual school districts can provide their own tutors or contract with an agency that provides this service. Parents may also want to supplement this tutoring with volunteer tutors or private contractors. Classroom teachers may want to volunteer to work with their students at home or in the hospital, but this should be supplemental to the contracted tutors. It's a big commitment to tutor a child with cancer who may be out for months and need daily instruction. We applaud the classroom teacher who wants to take this on, but it is too much to expect given the time commitment of their regular job. If the classroom teacher would like to commit to regular visits where some schoolwork can be discussed or done together, that may be a better option. Schools should also be aware that if a student attends a parochial school, charter school, or other private school, the student's family may decide to enroll their child in their home school district to obtain these tutoring services as well as other special accommodation plans or special education services as needed. Typically, private, parochial, and charter schools do not provide these services, so they look to the public schools to partner with them to provide them. So be aware that you may have children from your district who are not known to you because they have been in a private setting now enroll after diagnosis. Once the arrangements for tutoring have been made, there needs to be close communication between the classroom teachers and the tutor or tutors providing the service. They should be exchanging contact information and sharing information about curriculum and lesson plans. It is advisable to meet at least monthly to assess the progress of the student. Teachers will need to modify the curriculum for the student. The student will not be able to complete every assignment given in the regular classroom due to their fatigue and side effects. They will quickly become overwhelmed unless the teachers can make appropriate modifications. Essential assignments need to be given, so they will have proper preparation for return to class, but modifications can be made by shortening assignments, reducing volume, changing format from written to oral, and avoiding copying and rewriting tasks. High school students especially may need to make further accommodations to their course load as they go through treatment if they are unable to keep up with even modified curriculum. Decisions may need to be made about postponing some coursework that is hard to replicate in a tutoring situation, such as lab sciences or foreign language courses. Tutors should keep a regular schedule with the student. Hospital personnel are usually good about not interfering with tutoring time for patients. At home, the parent should be sure to set aside a quiet place for the tutor to meet with the child. In addition to the tutoring schedule, students should be prepared to work on assignments on their own or with the help of family members as much as they can handle. It's very important that the tutors and teachers establish a way to grade the students for their work. Sometimes the tutor will return all completed work to the teacher and grading will be left to them, or the tutor can grade the assignments. It's recommended that the student be given a grade on their report card based on the work that has been completed. Frequently, the school will register a medical incomplete on the student's report card. This can be demoralizing for the student who has worked regularly with the tutor during their illness. They need the feedback from their teachers as to how they are doing, just as every child does. So we recommend grades based on whatever has been completed by the child during the grading period. If the child is unable to complete all essential assignments during the regular school year, tutoring can be extended so that they have time in the summer to complete coursework. Soon after the child's diagnosis has been shared, school personnel should consider sharing that information about the student's illness with the classmates and faculty. The contact person should speak with the parent about this and get their permission to conduct the visit and talk with the parent about what information will be included. Some parents may have restrictions about what they want revealed to the classmates, so this should be cleared with the parent before the presentation. The hospital may have an educational liaison who can conduct this type of visit, or it may be left to one of you, the classroom teacher, nurse, social worker, or guidance counselor, whoever is most comfortable doing so, to speak with the classmates and the teachers. Hospital personnel can help to support the plan for the visit by providing patient-specific information and also reinforcing with the family the need for this discussion with classmates, as it helps to provide support for the child, quells rumors at the school, and can reassure classmates that their friend is being taken care of. The presenter can talk with the parent about who should be included in the visit. Sometimes it is just the child's classmates, or with smaller schools, it may be the whole grade level. If there are siblings attending the school, the parent may want them to attend also. Rather than an entire classroom, middle school and high school students may want to create a list of close friends that they feel comfortable having information about their diagnosis and treatment. Parents may also want to attend. However, it's advisable that they are not there, as their presence may inhibit children from asking questions about their classmate, and the parent may be very emotional talking about their child, and this might be upsetting to the classmates. The purpose of the presentation is to talk about their classmates' diagnosis and treatment and how the medical staff is making them better and what they can do to be a friend to them. I'll describe the elements of this type of presentation in the coming slides. So here's a blueprint of what to tell the classmates at the presentation. The person making the presentation to the class should speak with the parent about how the child was diagnosed. Perhaps they had a fever for a long time, and parents brought them to the doctor's office, and lab work revealed the cancer diagnosis. Or they had pains in their legs and found it difficult to walk. Or in the case of a brain tumor, perhaps they had persistent headaches. Tell the story of how they were diagnosed and what the doctors are doing to make them better. Remember to use correct terminology, including the name of the type of cancer they have. Use the words chemotherapy and radiation to describe the treatment they are receiving. Avoid euphemisms like bad cells or blood sickness, even with young children. Some time should be spent on what cancer is. Mike went into the disease process in depth for you, but for the classmates it can be defined as simply as the growing of abnormal cells that interfere with healthy cells. It is also preferable to engage the children in the class by asking questions like, does anyone know the 3 types of blood cells and what they do when they talk about what happens in leukemia patients? If there's a puppet or a doll available to show where the tumor is located or where the central line is placed, that can be helpful for the children to visualize the information. Oh, I got to go back. Describe the treatment to the classmates and how it will make the child better. Some treatment starts with surgery to excise a tumor. Talk about the purpose of the surgery and that the child was asleep and given medicine so they wouldn't feel any pain. Chemotherapy can be described as special medicines that kill the cancer cells and that it is administered through a Broviac or port so that the child can avoid numerous painful needle sticks. If radiation is part of the treatment, it can be described as a strong light beam which kills cancer cells that may be hiding in other parts of the body that the medicine can't get to. Remember to keep it simple. Side effects. As this classroom visit is most likely occurring soon after diagnosis, there may not be any physical changes from the treatment yet. But if there are obvious physical changes or anticipated changes, they should be mentioned so that the classmates are prepared when they see their friend at their home or in the hospital. There may be scars from surgery or Broviac placement. Talk about hair loss as a side effect of the chemotherapy and that it is temporary in most cases and will grow back over time. There can be weight gain due to certain medications or inactivity, or weight loss due to nausea or vomiting. The child may be easily fatigued and may need to rest periodically through the day. It's important that the classmates know that their friend is immunocompromised or in a weakened state and can't fight off all the germs and bacteria and infections as well as healthy children can. That may be why the child cannot attend school regularly, and also why, if they visit their friend at their home or in the hospital, they need to be healthy and should avoid visits if they are sick. There may be a long list of side effects that the child has from the disease and treatment, as Mike previously mentioned, but many are not necessary to reveal to the classmates in this visit. Cognitive effects, problems with toileting, mouth sores, etc., do not need to be shared with classmates, as they can prove embarrassing to the child and are not necessary to know about for them to be supportive. Dispel myths. Be sure to dispel any myths about childhood cancer. As Mike described for us, it is different from adult cancer in that we don't know what causes it. Tell the classmates that we don't know how their friend got cancer, but we do know that it is not because of the foods he ate or the thoughts he had or because of something the parents did or because of where he lived. Ask the children what contagious means, and then ask if they know of any illnesses that are contagious. Then let them know that cancer is not contagious. You can't catch cancer from someone who has it. It's all right to be with them or sit near them. We are more worried about something that the child with cancer could catch from their classmate, like a cold or flu, because of their immunocompromised state. It's a good idea to talk about the rarity of childhood cancer. They may never know another person who gets childhood cancer. Even though the incidence seems to be growing, it is still a relatively rare disease. This may also reassure children that they are at a low risk to get cancer themselves. Share ways the classmates can be a friend to the child with cancer. If the child is well enough to have visitors, that should be encouraged. The classmates should always call first to see if they can have company. Sometimes children don't know what to do when they visit a sick friend, so suggest bringing a game to play or watching a special TV show or sporting event together on television. Be sure not to ask a lot of questions or tease their friend because of physical changes. It could be a time for the classmate to talk about what is happening in school or within their social circle. Even though the student may not be attending school, there may be times they could attend special events like birthday parties or special sporting events. Be sure to at least invite them, and then the family can decide if the student is strong enough to attend. Let the classmates know that they should help others throughout the school know about their friend's diagnosis if they ask, and be supportive. Finally, ask if the children have any questions about the information that has been shared. A classmate may ask if their child will die. Answer frankly that cancer is a serious illness, and certainly some children do die, but the doctors are treating their classmate for cure and are optimistic that they can make their friend better. Other ways that classmates and school personnel can provide ongoing support include communication via telephone, cards, letters from the class, or individually. Using Skype or speakerphone can bring the child right into the classroom to participate in a short activity with the class. Classmates can put together a video or recording of a lunch period or a more formal class event to share with their classmates. Many times classmates provide support at diagnosis, but this support can fall off over time. Remember that a cancer diagnosis and treatment may keep a student out of class for months, so ongoing support is recommended. Organize weekly contacts so that the student can be thought of as part of the class despite their absence. There is a program called Monkey in My Chair that is designed to share ways to keep the absent student connected to the classroom. The student's chair has a monkey doll placed in their assigned seat, and communications from classmates are collected there, as are all handouts to the class. Then everything is sent home at regular intervals so the student can see the notes of support or what is happening in the classroom. That works best in a self-contained primary elementary classroom, but with older students, the guidance counselor and a group of close friends might be called upon to develop regular communication with their friend using some of the ideas that I mentioned. A faculty or school personnel presentation is also advisable. Include any teachers or other school personnel that may be involved with the student. That might include principal, classroom teachers, PE teacher, guidance counselor, nurse, social worker, and the tutor if that's been arranged. The parents may want to attend this presentation, and it may help facilitate exchange of contact information and the logistics of how the teachers will assist with the home hospital instruction. This presentation should have the same elements of the classroom presentation, including describing the disease, treatment, and side effects. In addition, there should be discussion about how the side effects will impact the student's learning. Short-term side effects, as outlined previously, may include fatigue, stamina, and attention problems, and they may affect memory. There also may be problems with peripheral neuropathy in the hands that will impact graphomotor skills. This information is important so that the teachers can take this into account when making modifications in assignments for the student. If the child is at risk for cognitive late effects of treatment, such as those patients with brain tumors or radiation to the brain as part of a leukemia protocol, plans for eventual baseline testing can also be introduced at this presentation. Something happened. Okay. In order to provide support to the family, it is important to understand all the stressors they are under. So let's take more time to discuss these. The number one stressor to a family is the fear of losing their child. Even when the child survives, parents can grieve the loss of a normal childhood, or perhaps grieve for their healthy child that now is so ill, or may have permanent physical or cognitive changes. Feelings of helplessness. Parents who want or need to be in control of things will have a hard time if their child is diagnosed with cancer. They must rely on so many different people to make their child well: doctors, nurses, lab techs, pharmacists, radiologists, etc. Even if parents are able to get their child's care at one place, it is still difficult to coordinate all the care in an efficient manner, and that will be very frustrating for parents. Financial. When a child is diagnosed with cancer, one parent usually becomes the primary caregiver and may have to give up their job, creating financial stress. For single parents, they may risk losing their job or having problems at work because of their need to be with their child at medical procedures, hospitalizations, or because of the length of treatment that requires them to miss so much work. They may have to rely on people outside immediate family for help with caregiving. There are also a lot of out-of-pocket expenses: hospital meals, parking, babysitting for siblings, as well as gas for the numerous visits to the doctor and the hospital. There is an inevitable disruption to the family routine. There are schemas or roadmaps that let the parent know in a general way how the treatment is going to occur and appointments that need to be made, but there are always delays, complications, mix-ups, etc. So it is hard to plan your life, take vacations, see friends, go to the store, and meet the needs of the other children in the family. As Mike described previously, siblings can have a range of emotions when their brother or sister is undergoing treatment. Depending on their age and what the family has shared about their sibling's diagnosis, they may feel afraid, left out because so much attention is paid to their sibling, and consequently jealous of the attention, which might include gifts and special times for their sibling and not them. They may also feel guilty for not being the one who is sick, and also relieved that it wasn't them who was diagnosed with cancer. Some also feel embarrassed, especially if their brother or sister has gone through significant physical or cognitive changes and no longer looks or acts the same. Schools may notice changes in siblings' grades, behavior, or interpersonal relationships as a result of these stressors. Counseling programs for siblings may be provided at the hospital caring for their brother or sister, but we encourage schools to also put siblings of cancer patients on their radar and have counselors check in with them to see how they are coping and give them some additional individual attention during this time. And finally, there tends to be a magnification of interpersonal problems when a child is diagnosed with a cancer. Marital problems become more obvious. One of the biggest causes of divorce is caring for a sick child or the death of a child. If a parent has mental health problems, it becomes more magnified in this environment because they now have to deal with many new people and have new demands on their lives at a time when they are already stressed with anxiety about their sick child. Many schools want to support the family as well as the student while going through cancer treatment, and we encourage that. Here are a few guidelines for that support. Before you plan any support for the family, please get permission from the family through the contact person. Some families will welcome the outreach, but others may want to keep things as private as possible and will not want a school-based outreach. With parental permission, the school community might organize meals for the family a few days a week, arrange for babysitting of siblings, or picking them up or giving them rides home from their school sporting or extracurricular events. Schools may want to organize fundraising events on their own or in conjunction with agencies that support childhood cancer. Schools may organize events designed to show solidarity with the student, and that may include having a group shaving their heads, pep rallies with t-shirts with child's name on them, or even balloon releases, to name a few. There is a website called Caring Bridge that enables families to update interested friends and families about the day-to-day status of their child. Many parents use this as a journal and even post pictures of their child. It is also a way that well-wishers can easily contact family with words of support. It helps to reduce phone contacts that families have to respond to, as well as reducing the necessity of repeating the same information over and over about how their child is doing. If the parent is using Caring Bridge, this is a wonderful way for the school community to stay engaged with the family prior to the child's return. The time will come when the child will be able to return to school. They most likely will still be on treatment, but now well enough to attend fairly regularly. The school should be keeping in close contact with the family and medical provider to project when the child can return. Our next webinar will address this reentry time, but in anticipation of the inevitable return, there are a few things for the school to consider. Transportation. Many times parents will want to transport their child to and from school at least in the beginning of their return. Other times a special bus may need to be arranged, possibly door-to-door transportation so the child does not have to walk to a bus stop or wait outside during inclement weather. Or a bus with accommodations for medically fragile students may need to be arranged. A modified day may need to be considered, and therefore class schedule may have to be altered to accommodate this. Sometimes it's difficult for children on treatment to make it to school early in the morning or stay the entire day because of fatigue. Schools should devise a schedule where they come in an hour later and leave after lunch to help accommodate these issues, but that will need planning in weeks before the child returns to school. The child will more than likely need at least a 504 plan or possibly a CSE referral if there are significant physical or cognitive changes from the cancer and its treatment since diagnosis. Tutoring may need to be kept in place at some level to allow for frequent but sporadic absences due to medical appointments and continued side effects. These arrangements take time to put in motion and should be done in advance of projected return, so the child is not held up from returning as soon as possible. Okay, there. Schools should have pertinent emergency information in writing from the medical personnel prior to the child's reentry. Knowing this information will reassure parents that the school will be able to take care of their child at school, as well as reassuring school personnel of what to do to meet the child's needs. The hospital usually has print information about what to do and who to call in regards to issues with handling the Broviac, port, or possibly an infusion pump, what to do if the child comes down with a fever, and what to do in case the child has been hurt at school or on the bus. Schools have periodic drills for evacuating the school population, and there may need to be a special evacuation plan written for the returning student who may have physical changes and now requires additional assistance during a school evacuation. Finally, it is possible that a child could return to school who had a do not resuscitate order on file. The school will need one also on file and understand what their responsibility is in the unlikely event something happens at school that would activate this. Some other issues to consider. State tests are administered every year in each school. Children who are absent on the date of the test usually have a make-up day to take the test upon their return. Children undergoing cancer treatment may not be well enough to take these tests, even on make-up days. Schools are required to get students to participate as much as possible, but it just may not be feasible to have these children take the state tests. Schools can ask that the medical provider write a letter stating the diagnosis and treatment and asking that they be excused or exempted from taking the state test due to illness. In some cases, the child may be able to come back to school for the day of the test, but may need to take it in a separate room with extra time as an accommodation. There may also need to be permission given by the state to allow for this type of accommodation, and so schools should be aware that this has to be arranged in advance. High school students who want to take college entrance exams will also need the school's assistance in requesting accommodations for taking those tests. We recommend that you contact college boards early to obtain appropriate permission for accommodations for those tests. Again, the medical provider should write a letter documenting the need for accommodation. Occasionally, the parent, for whatever reason, may consider not returning their child to school after diagnosis, but instead taking on the responsibility of homeschooling themselves. We do not encourage this, as we feel the parent will have so many other responsibilities that teaching their child will be overwhelming for them. However, despite this advice, some families do elect to homeschool. Sometimes they homeschool only during the most rigorous treatment phase, with plans to return to the school district after that part of the treatment is over. We believe that even if they do elect to homeschool, it is still important to keep up support for the family through regular contact and other ways we have described to help this family in your community. More than likely, this child will return to your district and you will have maintained a good, supportive connection with this family, easing the transition back. We hope this information about how to support a student diagnosed with cancer before they re-enter school is helpful. Keep in mind that the overwhelming majority of these students will return to your school to complete their education, and a knowledgeable, supportive, and constructive response by the school community to a student's cancer diagnosis is vital to the student's success in school. Communication, ongoing support, and comprehensive planning for their re-entry is necessary, and it will be rewarded with grateful parents and a well-adjusted student.
Thank you so much to both of you for those really wonderful presentations. We have some time for questions. If you have a question, you can type it in the question window or the chat window if that's available to you, and our speakers will try to get to them. I want to start with a couple questions that people typed in during the webinar. The first is, and I know that you both went over this briefly, but one of the questions that's common for teachers and school personnel to get is, could I get cancer from other students? Do you have any suggestions for how to address that question?
Well, I think in the classroom presentation, that really should be a big part of the presentation to talk about that it's not contagious and that you can't catch cancer. And I know in the environment today there's a lot of talk about contagion, so it's probably even more important to really stress that in the classroom presentation. And you can talk about other diseases that are contagious just to show the difference between that and cancer, and that they should not worry about that.
I would definitely agree with that. It is still, even in this day and age, not uncommon for parents of other kids in the classroom to tell them stay away from that child who's sick, or stay away even from their well siblings, because we don't want you to catch cancer. So it will come up, and it should be addressed directly, and it just does not happen.
And just as another thing that I've done when I would do these school visits, sometimes we would send out a letter to the classmates before I came in to do a classroom visit, telling parents, hello? Telling parents that we were going to have the presentation, telling what we're going to talk about, to kind of reinforce the fact that it is not contagious, and that if any of them had any questions, they could contact the classroom teacher and even me if they needed to.
Okay, here's another question. Are you, either of you, aware, and we also have our two other panelists, Katie and Mindy, for the next webinar on the line. Are any of you aware of any studies about differences between students who stay home from school during treatment versus students who do attend school once in a while during treatment for health and academic outcomes?
Well, this is Mike. I think I don't know of any formal studies off the top of my head about academic outcomes, although I could certainly imagine that if a student was more integrated into what was going on in the classroom, that they would be more likely to be engaged and keeping up with things. But I think that from the social developmental perspective, that these students are already struggling with issues that make it more difficult for them to perform the usual kinds of tasks that they should at whatever age level they are. They feel separated from their social group. They feel different from everyone else. They feel incapable of doing the things that the rest of their classmates are doing. And if they're isolated from that even more by staying at home throughout the entire time that they're on treatment, then all of those feelings would just be accentuated, and they wouldn't have the opportunity to maintain the social contact and to have validation for some of the things that they are able to accomplish. So from that perspective, I think it definitely has a negative impact on their potential to be successful going forward.
Well, and also, Mike, as I said, they don't get a lot of tutoring. I mean, it's only 5 to 10 hours a week. That's not a lot of instruction time, and you know, it can be enough if it's regular, and if they can get back to school relatively soon. You know, even I think anything over 4 months out of school, I worry about someone who's going to be missing that much school even with tutoring. So I think it's important for them to get back to get the full richness of the curriculum, which they really can't get in a tutoring situation. Although it is necessary to have the tutoring, but it's still better if they could be in school.
Absolutely.
Okay, there's another question which is about examples of presentations for students of different ages and faculty. I know that the presentations that you've done today are really, really great guidelines for how to go about presenting to faculty, to other school personnel, and to students. Are you aware of any canned presentations anywhere else, or would you advise school personnel to use the material that they've been given here today to help craft a presentation for their school depending on the age of the students?
Actually, our new people are going to talk about that at the next webinar. Go ahead, Katie and Mindy.
Yeah, we are going. Can you guys hear me?
Yep.
We're going to get much more into age-specific school presentations in the next webinar. That you can, you know, sort of developmentally the information needs of early childhood, middle childhood, adolescence. And certainly there have been times in the past that your local leukemia and lymphoma society have done some trainings, and you might be able to log on to their website and see if there are any coming up soon. But we want to prepare you for that in the next webinar.
And I think the other thing to keep in mind, if the hospital that is treating your student has a professional like Kathy who can come to the school to do the presentation, that's terrific, and you should certainly check with them to see if that service is available. But even if they don't, people at the hospital would be more than willing to talk to the classroom teacher or the counselor or the school nurse or whoever was going to be organizing that kind of a presentation and give them some additional advice about how to tailor it for this specific student at whatever age they are and depending upon whatever the medical issues will come up. So feel free to call on the professionals at the treatment center to get some additional advice and support.
Okay, here's another really interesting question. What do you recommend about siblings in terms of class presentations? Do you recommend presenting information about cancer to a sibling's classroom as well as to the patient's classroom?
I have done it. I think sometimes if it's a smaller school where everybody knows everybody, I've done that where I've gone to the siblings classroom. It's better if the siblings class can actually come in and join the presentation we're doing because, you know, time resources can be difficult. But yeah, especially if the parent wants it. Sometimes they'll just want the sibling in the class. But if they know the sibling that has cancer and all of their friends know it, then I think it makes sense to have as many people who know the child get that information.
That it helps if the sibling isn't left in the position of being the sole provider of information in their own classroom. If they kind of hear rumors that the other child has been diagnosed and they talk to kids from that classroom who've heard some explanations but they haven't gotten it themselves, then they might be peppering the sib with questions all the time that they may feel uncomfortable answering, not know how to answer, or be embarrassed about answering. So that's one point, that it helps to disseminate that information. Kids, if they know what's going on, are less likely to make fun of people and be mean, which we know that they have the capacity to do sometimes. The more they understand, the more understanding they will be able to be. The other people who I think really need to be cognizant of the issues that the SIBs are facing are the siblings' classroom teachers, because often they are very understanding and supportive of the family and the patients, but they get sort of irritated with the siblings because they're healthy and nothing's wrong with them, so why are they not performing in school, or why have they become a discipline problem, or whatever the issues are. I think it's really important to remember that they are under an extraordinary amount of stress as well. They often feel abandoned by their family. Often they'll be bouncing around from friends to friend or to relatives while the parents are away at the hospital with their brother or sister who's ill. Oftentimes they will be asked to take on responsibilities for caring for younger kids, or taking care of the house, or cooking meals. Oftentimes there will be no one there for them to help them with their homework, or even make sure that they get it done. So the classroom teachers should expect that those SIBs are going to have some issues, and be prepared to be supportive and help them to cope with that, and not get irritated or upset with them. The worst thing you can say is, how can you possibly do this to your parents? Do this meaning flunking this test or not doing your homework or whatever it might be, when they're facing so much of a problem with your brother or sister who's sick, because that just reinforces the message that no one cares about the sickness.
Thanks. Okay, I have a question that may be better addressed in the next webinar, but I don't know if, Mindy, you might be able to touch on this a little bit. Someone asked, what research is available on the emotional long-term effects of adolescents diagnosed and in remission from cancer?
Well, the reason that we are doing these webinars is to buffer these children against emotional long-term effects. It really is the adolescent's developmental task to develop their role identity at this phase of life, and when they are pulled out of school, it very much interrupts that developmental task. So, adolescents who are able to be successfully reintegrated into schools with very good support can do quite well in the long run, especially when there are adequate if you're adequately addressing their educational needs, identifying educational issues that come up when they come up, rather than letting them stew and having them impact the child's self-esteem. And really the goal is for these children to function at a high level in the long run. These children, the interesting thing about what Mike just mentioned about the siblings are that much of the research shows that siblings actually have much worse long-term psychological outcomes, because all of the providers, all of the teachers, all of the support people are so focused on the patient and getting the patient through this very dramatic and traumatic episode in their lives, and they do receive quite a bit of services, whereas siblings receive very little and are often left feeling guilty and abandoned and angry and misunderstood, but not feeling they have the right to reach out and get help. So it's interesting how resilient many patients are with the right level of support.
Thanks, Mindy. I would also add to that.
This is Katie.
Go ahead, Katie.
Oh, I was just going to add to that. I think that, the overwhelming majority of childhood cancer survivors do well psychosocially in the long term. There's a small group are going to have problems long term, but as Mindy was saying, a lot of these things we can do now can help prevent that or buffer that. The research on adolescents in particularly is relatively new. They're a group that usually in the past, because the numbers of the numbers of pediatric cancer patients are not really huge in any one study. They usually get mixed in with children, but And in the last decade or so, they've really been a focus of research. And the research does suggest that adolescents might be more vulnerable to some of the negative effects and might need some of these extra services to help promote their resilience. So they can be resilient, but they might be a more vulnerable group that we should watch out for.
Thanks. I would add one piece to that, which is for the person who asked this question, that we at CureSearch are also funding a really wonderful researcher who does studies on resilience and stress management techniques, especially for adolescents and young adults diagnosed with cancer. And I would be happy to send some more information about that directly to you if you're interested. So we have time for about one more question if anyone else is interested in typing one in. I'm going to ask the penultimate question, and then if you have any more, feel free to type them in the window. One question for Kathy is, how do you choose a good case manager? Can you provide any guidance for how to pick a good person at school to help?
Well, it should be someone who who wants the job. I also think it's somebody who's going to have to be comfortable with the information. I've probably done about 1,000 school visits in my history, and sometimes it's interesting. Some people just aren't, some adults, because of their own history with cancer or family members who had cancer, aren't comfortable talking about it. And you want to stay away from that person. You want to have somebody who is comfortable, who feels at ease, who can, talk about what might sometimes be difficult conversations with the family, and also who can be empathetic and who has a direct line to that child's education. And so a classroom teacher, a school nurse, sometimes guidance counselor, someone who understands the importance of them staying in connection because of the academics and also because of the social issues.
Okay, thank you so much. I think it's about time to wrap up. This webinar is being recorded right now, and I will send it out to everyone who's registered, so you will be able to view it online afterward. Thank you so much for joining us, and thank you to Mike and Kathy for their really wonderful presentations. We hope that you join us at the next webinar. It's open on the slide right now with a link to the registration. It's going to be November 3rd. Which is in 10 days or so. So I hope to see you all at the next webinar, and thank you so much again.
Are we still here?